Thank you very much for including me as well. I've been working in this field for over 25 years, and Stargardt disease is a very important part of my practice, both clinically and in terms of basic and clinical research. And it's just been very rewarding to see how much things have advanced in 25 years. And I hope that we will continue doing as well as we have. And we're happy to answer questions today.
Thank you for your generosity and your time with us today. All right, so here's a starter question. Does it appear more likely that there would be a genetic or stem cell treatment or cure for Stargardt's sooner? Is there anything that looks like a promising treatment or cure that we can have available over the next year or two?
Okay. I can start with this, and then Janet can chime in. Stargardt disease is a very challenging disease, and we'll get into some of the more the details of some of the various interventions that are out there. From this questioner, you're looking for things like stem cells. You're addressing stem cells and gene therapy. They are two very different approaches there, and there are several other approaches that are out there too that may be a little sooner to clinic. Gene therapy is designed to correct the genetic defect, and I may leave that to Janet to talk about a little bit more in detail. But the genetics, if we're going to be trying to correct the gene that causes this problem, which is the ABCA4 gene, we're looking to stop the disease in its tracks, basically. We're not going to reverse the process and really effectively restore vision. But this is a very important approach to be doing gene therapy. The problem is that the ABCA4 gene is a very large gene, so there are technical issues that make it harder than some of the other gene therapies that have made it into clinical practice. And there also are many, many, many mutations, probably the most in almost any gene that we know of that causes an eye disease. And so that makes it challenging. So I still think it's years away, but clinical research can put it on the 5 to 10 year horizon I'd be hopeful for. Stem cells are designed to actually are a restorative process, and there's a lot of interest in trying to introduce cells and address the fact that cells are dying in the retina. This sometimes is preceded too much by the hype of the internet and very small studies that are exploratory that get magnified. Stem cells need a lot of work still. We can get cells underneath the retina, but we can't always make them do what we need them to do. So I still think that's some years away. The third approach is to try to slow this down with various inhibitors of the visual cycle and other things that are more in the realm of pharmacology. And those are closer to and are already in clinical trials. And I think those are the ones that are nearest term. And we'll talk more about those as well. So I'll leave it to Janet to chime in more here.
Yeah, oh, thank you very much. Yes, Paul, you gave a very nice summary. I'll just add that gene therapy is very desirable because one can actually consider it to be a cure. You're really replacing the diseased, mutated gene. As Paul said, the ABCA4 gene is very large, and therefore one of the difficulties with gene therapy for recessive Stargardt's disease is the packaging of the gene and how it can be delivered to cells by a vector. And many of the vectors can't carry a gene the size of ABCA4. But even given the success with gene therapy for another retinal degeneration, RB65, I think that gene therapy is certainly something that we all are hoping for and working toward. The cell therapy is complex also, as Paul has said. In recessive Stargardt's disease, the mutated gene, I think you all know, is actually expressed in photoreceptor cells, but it's the output of the mutated gene that is causing the degeneration. Is that process is ongoing in a different set of cells, the retinal pigment epithelial cells. So that's kind of complicates the issue, because if you replace the easiest cells to replace would be the retinal pigment epithelial cells. But then, and that could give a patient return of vision, but you still haven't cured the disease because the mutation is still sitting in photoreceptor cells.
Excellent. I think based on your introductions, we're seeing a lot of questions around your expertise as well, including nutrition. So why don't we move to a couple of nutrition questions here?
Okay.
Here's one. Can you comment on diet, specifically vitamin A, and how it impacts the progression of disease?
Okay. So diet is very important for many eye diseases, and including age-related macular degeneration and Stargardt disease and retinitis pigmentosa. And of course, diet is something that all of us are concerned about, and is something that where the patients can be empowered to really be participating. But the problem, of course, with dietary interventions are that the science doesn't always catch up. And so we have to sort out what is good knowledge and what is not so good knowledge for treating diseases. So with regard to Stargardt disease, through the work of Dr. Sparrow and others, we know a lot about the biochemistry of how diet can interact with this disease. So we've talked about that recessive Stargardt disease, which is the most common disease form of Stargardt disease. And there are, just to kind of put it in perspective, and many of you may know this, there's somewhere around, we estimate around 30,000 people have Stargardt disease. And greater than 95% of patients with classical appearance of Stargardt disease have a mutation in the gene called ABCA4. And this gene is known to be involved in transport of vitamin A in the eye. And vitamin A is very important. That's the pigment that we have to detect light, and it has to be transported back and forth between the photoreceptors, the rod and cone cells, and the retinal pigment epithelium that Dr. Sparrow has talked about. And ABCA4, when it has a defect, there is a problem in the processing of vitamin A, in that it doesn't move well out of the photoreceptor cells and into the retinal pigment epithelium cells, and it starts interacting with some other compounds in the eye, specifically phosphatidylethanolamine, and generates a series of toxic compounds, the most notable of which is A2E. Now, so because A2E is involved with vitamin A, we are interested in knowing whether vitamin A could be a problem for this. And there is a growing evidence that too much vitamin A can contribute to even more increase of these toxic compounds. So unlike retinitis pigmentosa, where there are certain forms where there are clinical studies that suggest taking high doses of vitamin A may be helpful in those patients. In Stargardt disease, in the animal models, and also in our clinical work, we generally recommend that people do not take excessive doses of vitamin A, the 10 to 15,000 units that we recommend for retinitis pigmentosa. This was a problem years ago because sometimes we weren't sure exactly what the mutations were and who had Stargardt disease and who had retinitis pigmentosa. So that now that we do genetic testing, we know the people with ABCA4 mutations, and we can advise them to take just a normal diet, not excessive doses of vitamin A. The vitamin A comes in two different forms. You can have preformed vitamin A, which is probably the most worrisome form, but that's the one that we prescribe to retinitis pigmentosa patients. But beta carotene is the one is a precursor, and that one's a little more regulated and it's probably safer. So a couple thousand units a day in a multivitamin is not a problem, especially if it's in the beta carotene form. The other nutrient that I'm particularly interested in are the compounds that form the macular pigment, the lutein and zeaxanthin, and they are concentrated in the macula. And we have a fair amount of evidence that in Stargardt disease, those levels are low. That we know that lutein and zeaxanthin are protective against age-related macular degeneration, prescribe that for them. The question is, can we give supplements to, what are the value of supplements of lutein and zeaxanthin for a patient with Stargardt disease? And the answer is, we're still not sure. The levels are low, I think, because cells are dying away, and the cells that normally carry the lutein and zeaxanthin and hold it there are going away. I think it's safe to take lutein and zeaxanthin at the doses that we prescribe to age-related macular degeneration, but we don't have evidence that it really is protective against the patients. And in my clinic, we have some specialized ways of measuring the levels so we can tell who has high and low levels in their macula. Then with regard to other nutrients, it's a little more difficult to say whether zinc or vitamins and other things, the CoQ10, bilberry, a lot of them are just unknown right now, and the patients should at least be, I still emphasize a healthy diet as the number one way to address this. And, but in the absence, if you do want to take a supplement, then take things in moderation. I think excessive doses of just one vitamin are not, without a lot of evidence, are probably not helpful. So I'll leave it to Janet. Do you want to add more about some of the vitamin A?
Okay, thank you, Paul. Yes, I think Paul described the problems with vitamin A very well. We all need vitamin A, it's very important, but it's equally important that individuals with recessive Stargardt disease do not overtake vitamin A. It's really not advised, because it actually becomes part of the problem. What I will give perhaps more importance to antioxidants. For instance, an antioxidant like vitamin E. These are important because probably one of the pathways that leads to retinal pigment epithelial cell death is through photooxidative processes. And antioxidants like vitamin E, which can be obtained readily through a good diet of lots of vegetables and fruit, will give individuals the kind of levels of vitamin A that could be important to them. Alternatively, one can take them as a dietary supplement, vitamin E, but safe levels, obviously. But I think that these vitamins are and also vitamin E, vitamin C, lutein and zeaxanthin are recommended for patients with, I think, for patients with Stargardt disease, and it's a good thing.
So, and Janet and Paul, more specifically, we're seeing questions, follow-up questions around what a Stargardt patient should or should not eat. I know you touched on that. Can you just add to that a bit?
Diet, as we said, a diet rich in fruits and vegetables is important. It's important for all of us, but probably even more so for a recessive Stargardt patient. And dietary supplements that are taken at recommended doses. Maybe I'll just also add here. I think a lot of patients it's recommended that they wear sunglasses, and there's a lot of evidence that recessive Stargardt patients may be sensitive to high levels of light, and I think that's highly desirable that they should be recommended to wear sunglasses. And if they do, choosing a lens that has a yellow tint in it is probably most important.
Yeah, the only other thing I would add is, in terms of your diet, you would have to go out of your way to overdose on vitamin A with a fairly unusual diet. The only things that I can think of is if someone who was really into eating a lot of liver, because there are relatively few things in a normal human diet that have a lot of preformed vitamin A. Most of the vitamin A that we get is from beta carotene. That's what we get from most of our fruits and vegetables. And it's essentially, in a normal person and also in a Stargardt person, it's very, very hard to overdose on that, because we have enzymes that are regulated and don't make us become toxic on vitamin A. So that's, I think, as long as you avoid excessive supplements, excessive amounts of liver, but some of the things that you see out there, like vitamin A fortified milk, I think you'd have to be having an awful lot of vitamin A fortified milk to have a problem.
That's very interesting. And Janet, you mentioned sunglasses. I have to shout out to two blind brothers, Brian and Brad Manning, who started this company, Two Blind Brothers, and they have a wonderful pair of sunglasses that has a lifetime warranty, unlimited. So they've been incredibly generous to the foundation, and are both themselves Stargardt patients. Okay, so let's move on to some of the genetic questions that we're getting. So here's one that we received early on. My son has 2 genetic tests, and they only find one of the Stargardt mutations. Is it true that there needs to be 2 mutations to qualify for most clinical trials?
Yes, that so an individual can have the disease with only one of the mutations being identified, but in many cases there is a second mutation that just hasn't been recognized. But for the trials, so that the patients can be characterized sufficiently, I believe, and Paul can comment on this, that the identification of 2 mutations is necessary.
So I would say there's a few exceptions on that. Especially for gene therapy trials, I can say absolutely they will want to know, they would want to identify both of the genes that would be found in recessive Stargardt disease. There are some of the small molecule trials, they're a little more generous and inclusive, I would say. They allow one mutation plus a clinical picture that is very consistent with Stargardt disease will allow patients to get in. The challenge, as both Janet and I have discussed, is that the gene is extraordinarily large, and there are literally 1,000 different mutations that can occur. So things get missed. They can be complex mutations where there's whole deletions or areas missing, or areas called introns can be affected where it's in between the genes, and those can be hard to decide what is a mutation and what is not. Also, as our knowledge changes, things that we thought were not mutations and just normal variants just 5-10 years ago are being reclassified as we learn more. So just because a person has had only one mutation identified doesn't mean that will change. The final thing to remember is that mutations in the ABCA4 gene are very, very common. In the most recent review where they do an estimate on this, 1 in 20 of us just walking down the street carries a mutation in this disease. So as our knowledge of genetic testing, and we get these results back and they say, well, you know, is this real, or is this just a random finding that you're just a carrier and it's some other gene that can cause something that looks like Stargardt disease, something in the ELOVL4, PRPH2. There are a number of genes that can be very confusing to the clinician. So that's why we like to, for a definitive diagnosis, we like to know that the 2 mutations have been found. But sometimes our knowledge is just not good enough yet.
Excellent, thank you. As a follow-up to that, one question is, I was diagnosed with Stargardt's in my mid-50s by 2 different doctors, but have not had genetic testing. Should I also get genetic testing? And if so, how do I get tested? I can help answer the latter piece with the FFB, my retinal tracker registry as well.
Yeah. So with this, I definitely would recommend someone where there's a strong suspicion that there is Stargardt disease to be tested. The classic teaching when I was a resident 25 or 30 years ago was that Stargardt disease starts when you're in your teens or early 20s, and that it didn't happen when people are 40, 50, 60 years old. We now know that is wrong, that there are certain mutations that show up later in life, and I definitely have diagnosed people in their 50s with Stargardt disease. And we've learned that we probably were confusing it with age-related macular degeneration in these later onset forms. So yes, we do encourage genetic testing. Academic center, especially ones that are associated with the Foundation Fighting Blindness, usually will have the information on how to get genetic testing drawn through the My Retina Tracker program. My university at the Moran Eye Center, we use it extensively, and the Foundation Fighting Blindness has done an admirable job of stepping up and funding this initiative so that it is at no cost to the patient, as long as you're willing to fill out a short questionnaire online and provide some information so that FFB can help treat these diseases. They're very fast. They get back within a month, which for genetic testing is great. And my site has a genetic counselor that then goes over the results with the patients, but many sites don't have genetic counselors, but the Foundation Fighting Blindness will arrange for telegenetics, as we call it now, to help patients understand and explain the results. So I strongly encourage, talk to your doctor, but if they don't know the information, the Foundation Fighting Blindness can certainly help direct you to the right person.
Thank you, Paul. We're seeing 4 or 5 categories of questions, and as you would expect, therapeutics, nutrition, genetics, and then sort of the social side of things. So here's a great question. I'm an attorney in North Carolina, and I read a lot from my profession. What equipment do you recommend for someone with Stargardt's to operate normally within an office setting?
Do you want to try that, Janet, or do you want to leave that to me?
Yeah, I think you could try that because you probably are in a position to make these kind of recommendations more than I.
All right, from the main things that we recommend, well, first, let's start out kind of the basics. For Stargardt disease, this affects primarily the central vision. That's the complaint that many patients have, that they're having difficulty reading and driving, recognizing faces. Stargardt disease in its classic forms, and obviously there's a huge variation when there's so many people affected, affects the central vision, and patients commonly will go to legal blindness, which is 2200 vision or worse in the better eye, but they do not go totally blind, and they usually retain some reading vision, but they need reading assistance, and so that requires magnification, better lighting, and other strategies to increase contrast. And this is a very important part of managing and treating an inherited retina disease practice. I would say that we still are remiss with our residents and education and the number of ophthalmologists that are really skilled in the low vision services. And I freely say I am not an expert on this. But I have identified, and I think many inherited retina disease specialists have identified the people who can help with this. They're called low vision specialists. And we have one, and many academic centers will, and private practices may have people who are associated with this, and many states provide this as well. So typically people with Stargardt disease don't need to be learning Braille. They're not going to lose all of their central vision, but there are, as I said, the simple things of just magnification, learning how to use your computer to make to enlarge the font properly, to get better contrast can be very helpful. But there are some other more expensive and more technologically intensive glasses that have been on the market. Some of them can be pretty pricey, many thousands of dollars. And I would say some of my patients have tried them, but I think that a limited number do well, and they need good counseling from the people who do low vision services. So the bottom line that I recommend for someone who is working in a reading intensive job is to find out what's available in your area, ask for a low vision specialist, someone who has gone through the training and feels comfortable with this, and they can be of great help.
Great. And a follow-up question on the lifestyle, social side is, how damaging is UV light, and should children be wearing sunglasses throughout their earlier years as well?
Okay.
I'll take that one.
Yep.
So actually UV light for a retinal disease is not the light that we need to worry about, because UV is actually absorbed or blocked by both the cornea and the lens, and the retina is sitting behind the cornea and the lens, so we don't really have to worry about UV. What we have to worry about is blue light, because the damaging molecules that accumulate due to the mutations in the ABCA4 gene, those molecules are light sensitive, and they're particularly light sensitive in the blue region of the spectrum. So that's why I mentioned a few minutes ago that wearing sunglasses to protect the eyes from bright light is important. And actually, we all should be wearing sunglasses to protect our retina, but it's not the UV that's a problem for the retina. It's blue, and you can reduce the blue light by employing yellow filters in the sunglasses, yellow lenses.
And a follow-up to that, Janet, what is your opinion on the low vision prism glasses that are being advertised for this condition?
Yeah, so I can't comment on that, Paul. Can you?
Okay. Yeah, I can talk. I have limited knowledge and experience on this, but the idea would be that in patients with Stargardt disease, when they have central vision problems, they develop what's called a preferred retina locus. So they pick a different area that's not so dysfunctional in their retina that is offset. Now you can see this sometimes in patients with Stargardt disease, because some patients appear not to be looking straight at us. They're looking a little off to the side, kind of like a person on a Zoom call looking at their camera to the side. And I think that with the prism glasses, is they're trying to adjust it so that the vision is better and more focused and a little more straight on to their preferred retina locus. To me, that sounds difficult to do, but I would talk to a low vision specialist. Clearly, it's working for some people, but I don't think it's a cure-all.
Okay. This is a true-false question. And I think Janet just addressed this, but is blue light from a computer damaging for a Stargardt patient? There seems to be much conflicting guidance on this, given that we all spend so much time on our computers.
Yeah. So I don't think so. I don't know. No one's actually that I know of carried out a good study of this. But just from my use of the computer, I don't think the light is particularly bright, and so I wouldn't be worried about it. And even in a room lighting, well, I guess if you turn I guess actually you can make the computer screen very bright if you turn up the light button, but I myself don't do that. So maybe I just haven't experienced that level of brightness. But I'll go back to what I was saying, and that I don't think that it's necessarily a problem.
Okay, and then Janet, just to add to the UV light, blue light question, are there indicators of glasses that protect blue light, or do you need to purchase a filter, as you mentioned?
Yeah, so you can purchase sunglasses in which the lens is yellow. It's usually a dark yellow, like an amber color. Corning glass, I know, has a specific lens that's recommended right this minute. I forget what that number is, but I can certainly communicate with FFB to provide that information. But it's not a bright yellow. It's usually a darker, deeper yellow, more like an amber. That's highly recommended, and one can buy sunglasses with those lenses, or perhaps even by searching online.
Excellent. Okay, well, we'll come back to this line of questioning. We're receiving a lot of follow-ups. But let's shift gears since we're over halfway through the hour. We're seeing a lot of questions on therapeutic approaches, and one specifically on pharmacological treatments. Can you please talk through the variety of pharmacological treatments that are either in clinical trials or in preclinical testing to help the audience understand the prospects for each? It's a loaded question.
Yeah, I'll begin, and then Paul can join me also. So we were talking a few minutes ago about vitamin A and how one doesn't want to take vitamin A supplements or overload one's diet or with vitamin A. In fact, many of the therapeutic approaches, the drug-based approaches that are being investigated, many of these therapeutics aim to reduce the intake of vitamin A to the eye, or simply attempt to capture and immobilize some of the vitamin A derivatives that become problematic. And there are currently many different, maybe 6 to 7 different compounds that are being tested to handle these vitamin A derivatives so that they don't become damaging to the retinal pigment epithelial cells. The issues, of course, are very complex. The amount of vitamin A is necessary for vision, so the doses and the fidelity of the compounds have to be carefully titrated. And I think eventually there will be a small molecule, as they're typically called. There will be a small molecule that could become an important avenue of treatment.
Okay, so I can add in, Janet gave a good kind of overview, and since I'm also a clinician, I am an investigator in several of these trials, so I can say what we have seen so far. In trying to prove that a small molecule that modulates vitamin A is working, we have to do clinical trials. That means we have to recruit patients with bona fide Stargardt disease, so it requires, we typically will need to do genetic testing and either require, depending on the study, either, as we've discussed before, either 2 mutations or at least 1 mutation and a very characteristic look of Stargardt disease. And then once patients enter into these trials, since none of these drugs that are currently in trials are approved, you have to be randomized, which means that some people are getting the active drug and some are not getting the active drug. And that's the only way we can learn if the drug is safe and effective. The number of Stargardt patients is, Stargardt disease is certainly an orphan disease. There are under 200,000 people in the US with this condition, much less than that, about 30,000. But every study wants the ideal Stargardt patient. They want someone who has something that's very measurable on their pictures on their eye, because we don't usually use visual acuity as our outcome, because that changes too variably between patients. So you need to find, but there's a limited number of the quotes ideal patients, and everyone, even with me as a retina specialist I'm the inherited retina disease specialist for the Intermountain West. I probably cover the largest region in the United States. There's no other academic center within 500 miles of where I live. And so I have patients who are driving down 10 hours to see me, but there's a limited number of patients to get into each of these trials. And each of these trials, when we do this, there can be side effects that can be limiting. Some of these interfere so much with the vitamin A cycle that they cause some night blindness and color vision changes that may or may not be tolerable to patients. These are long trials. They typically are 2 years or so because the Stargardt disease progresses slowly. These are not restorative therapies. These are slowing down the disease. So we monitor these patients very closely. We have a number of promising compounds. Some of them affect transport of vitamin A into the eye. Some change the way the vitamin A is being processed within the eye so it doesn't build up these toxic A2E and lipofuscin compounds. There's a lot of promising things. There are others that are inhibitors of the RPE65 mutation. They're of the RPE65 enzyme, sorry, not the mutation. And there are others that are designed to try to clean out these toxic compounds. So there's a lot of things that are out there, but these are expensive trials. They take time, but we definitely encourage our patients to participate. And I'm very pleased of how most of these patients are very motivated and really understand what we're trying to do to help them.
I'll just also add, it's difficult to design the clinical trials. As Paul was saying, that every clinical trial wants to recruit the perfect patient that is in the stage of the disease in which the drug will be more likely shown to be effective. It's very, very important for us to continue to work on understanding the natural history of the disease, the natural history in terms of the damage to the cells and how the cells are responding. Because some trials, and I think this could be the case, for instance, with respect to age-related macular degeneration, when the patients are being recruited, it can be difficult to know what stage of the disease would be best protected by the drugs. And so I think people shouldn't become too discouraged with the results in the early stages of the trials, because I think that when we understand the disease itself better, we'll be more likely able to execute and interpret the results of these clinical trials.
Thank you, Janet. Paul, follow-up to that is, how would someone sign up for a clinical trial for Stargardt's? And what are the best locations for this? This came up yesterday a few times. It actually comes up quite a bit with FFB. And we know that a lot of the companies have dedicated web pages for their ongoing trials. But maybe you all can comment on your experiences.
Patients can also go into the website clinicaltrials.gov, which is National Institutes of Health website, which lists all clinical trials that are currently recruiting, or that are closed, or that are anticipating recruitment. And a lot of information can be gained from the website clinicaltrials.gov.
Mm-hmm.
And Foundation Fighting Blindness is a good resource. They won't know they're not involved in every trial, but they generally know most of the ones that are going on. And I think that you need to talk to your ophthalmologist, and if he or she is, a more general ophthalmologist and not comfortable, it is worthwhile at least having an evaluation with someone who does specialize in inherited retina diseases. Some are in private practice, but more commonly they'll be associated with a major medical center, and we're across the country, and the companies are very motivated. As an inherited retina disease specialist, I'm contacted. I'd say most of the companies will contact us at some point, so I'm aware of what is out there, and your regional inherited retina disease specialist will know about this. And you have to understand, though, that not everyone is suitable for these trials, as Janet was saying. There's some people who are too early, too late, or just not quite right. But once we have this figured out, if something is approved, then we will expand the use of these drugs. The good news is, Stargardt disease is primarily a disease of the eye. It's not affecting other parts of the body. So if we can get, sometimes that means we do treatment directly in the eye. The extreme is in age-related macular degeneration, where we're actually injecting just directly in the eye to get our drug in there. But other times, we can use targeted, well-designed drugs that just affect the enzymes only in the eye and have minimal side effects. So it's an interesting time, and we've made a lot of progress. I know it seems slow sometimes to patients with inherited retina disease, but really it's remarkable the progress we have made. And I think the years ahead, the horizon is drawing much closer for when we can say that effective treatments are on the horizon.
That's great to hear. And we talked about clinicaltrials.gov, which I believe is purely the US. Are there locations for trials outside of the US or a database outside of the US?
Trials ongoing in other countries are also typically listed in clinicaltrials.gov. I don't know if that's true across the board, but when I go in clinicaltrials.gov, I see trials from other countries also. So I think it's very broad database.
That's the most common one, but there are some other databases. There's something, I think, for Europe, the EU, but I don't know that, I can't give the exact information, but there are several. But clinicaltrials.gov is certainly the best to start with, and then you can do, but there are other possibilities too.
And for all of the attendees that are asking these types of questions, as Paul mentioned, you can go to FFB's webpage, and we will respond to all of your questions if they are not addressed in this particular session. All right, we'll come back. There's a lot of very specific questions around the pharma strategies, but here's an interesting question to shift gears a bit. I have a 1-year-old daughter and I have Stargardt's. Is there anything I should be doing for her as she grows in case she has the disease? Exams, wearing sunglasses, and should she be genetically tested?
Okay, I'm happy to take this one. So Stargardt disease due to ABCA4 is a recessive disease. So that comes down to, that means that if you have Stargardt disease, you inherited one bad copy of a gene from your mother and one bad copy from your father. That means your parents were both carriers of the disease. And we discussed that 1 out of 20 people just walking down the street are carriers of the disease. Statistically, 1 out of 4 of their children will get the 2 bad copies and get the disease. That means a patient with Stargardt disease, when they have a child, they're going to pass one of their 2 bad copies onto the next generation, in this instance, we're talking about a 1-year-old daughter. We know she's a carrier. It is pretty unlikely that she has Stargardt disease. And we can actually do the math is pretty simple. If the person has, if the person who, say the mother has Stargardt disease, and if the father has a 1 in 20 chance of being a carrier, the chances are on the order of 1 in, that they found the carrier, that she happened to choose as the father of her child, the 1 in 20, and then there's a 50% chance that she would pass, or then she would pass that on. We're talking about a very, very low chance that the patient would get this. It's only a 50% chance that the father who is a carrier would pass this on. We're talking about a 1 in 40 to less chance that the patient would pass this disease on to the next child. This is getting in the 1 or 2% range of birth defects and other problems. So it's very, very low. Right now, we don't encourage genetic testing, although that could be done. I think just normal eye examinations would be very reasonable for the child. and a normal healthy diet, because there's that, to protect them against other things such as age-related macular degeneration. With people who are carriers, it's still controversial, but there's probably a very small increase of chance of having problems with age-related macular degeneration very late in life. But again, even that is controversial, whether that's enough to cause problems. Okay.
Very nice. Thank you, Paul. So that's a really interesting response. So if it were your child, you would not likely have your child tested?
I probably would not. Right now, we don't usually do that.
Mm-hmm. Mm-hmm. And given the heterogeneity, genetics and presentation of the disease, one may know fairly early in life based on the exams and presentation. Is that right, Paul? And
yeah. I mean, they would have, it's going to be it usually presents in the teens and 20s, but when seeing something like this, where if a mother had it and then happened to find the 1 in 20 carrier and pass, and then their child would have it, that's what's called pseudo-dominant. It appears to be a dominant disease, but it's not really. Those are rare, very rare situations. And they get written up in journals. It's not something I would stay up at night worrying about, basically, if I had Stargardt disease.
Okay. So just a time check. We have approximately 20 more minutes. Thank you for your patience for those who are posting questions. We'll hopefully get to the majority of them. So of these categories that we discussed, I love this one because FFB is a healthy funding organization. Do we think all the research that should happen is being funded? What can the Stargardtian community do to help move things forward as fast as possible?
I'll leave that to let Janet do that one. At least start.
Yeah, so Foundation Fighting Blindness has been extremely important in terms of funding and assisting the research that needs to be done to lead to therapies such as gene therapy or small molecule therapies or a cell therapy. Unfortunately, all of these, the acquisition of the information that is necessary is difficult, and it takes time. So there's always more research that could be done, and so we are very appreciative. Investigators like Paul and I are very appreciative of the work done by the patient groups and by Foundation Fighting Blindness, because we know that the more work we can do, the better we will be able to assist in ameliorating the disease. So I would have to answer by saying that, yes, that we need to do more research.
Yeah, funding is always a challenge for us out there. We are writing grants. We're trying to get on the cutting edge, and it's competitive out there, and there's never enough funding, at least we feel, and that just like patients feel that we're never making progress quite fast enough. So it's a challenge. We go through, for us, like Janet and I, we have to fund our laboratories. We have to pay our people. We get funding from the National Eye Institute. We get funding from private foundations. We get funding from donors. So we're looking at all of this. The Foundation Fighting Blindness provides individual investigator grants but everyone thinks their disease is the most important. So it's a challenge to figure out how to allocate those funds. And then I will actually ask Russ to chime in on this, because he was telling us a little bit about the venture things. So, not only us who are working on as the individual investigator level, but there are companies out there and Actually, Russ, would you like to just talk for a minute or two about the venture side?
I'd be happy to introduce the Retinal Degeneration Fund. So this is the venture arm out of the foundation that was launched in October of 2018. And it's a nonprofit strategy where all the capital under management is donated by very generous donors, small and major donors. We have invested about 75% of Fund 1, which is approximately 72 million under management. And we're really trying to diversify the portfolio. As Paul mentioned, we have the task of addressing all inherited retinal dystrophies and dry AMD for that matter. So, it becomes a challenge to address all of the important constituents, but this is the first of its kind. It's a wonderful strategy. The granting program, the funding strategy feeds into this translational aspect of funding and investing. So it's very exciting, and we hope to grow this fund and subsequent funds. These are closed-ended sequential funds, and so we're currently raising for Fund 2. So thank you for mentioning that, Paul. So here's a question back to the heterogeneity of the disease. Is there a good validated way to predict how severe the visual loss will eventually be in an individual diagnosed?
Well, we know a little bit about mutations and how severe the mutation is for some for some cases. But as Paul said a few minutes ago, there are so many mutations, known mutations in ABCA4, in part because it's a very large gene, and must be also that it's particularly susceptible to variants or mutations. So it's hard to get a handle on the prediction of the disease severity based on mutations. The other complication is that, as Paul said a few minutes ago, we each have 2 copies of a gene, one from our mother, one from our father. And in Stargardt's disease, the mutation that we got from one parent is not necessarily the same as that we obtained from the other parent. And in some diseases, it's the same mutation, but not in recessive Stargardt's disease. So this becomes very complicated when we try to predict based on the mutation what the severity or the time course of the disease will be. And we only really we're beginning to have a handle on this.
Yeah, I think there are some recent papers by several groups, including some by Janet's colleagues at Columbia, that are really trying to dig deep into these mutations and predict which are the most severe and which have certain characteristics. And they are learning, but this is a tough gene to deal with. There's so much variability, and there's even variability between siblings who have the same mutations and they still look different. And clearly there's something about environment and other genes that are interacting with this, our diet, everything else, that makes it, clearly siblings behave similar, but they're not exactly the same.
Yeah, and Paul and Janet, one very important resource that the foundation provides one by one are natural history studies. And so the foundation has spent a lot of time and resources on ProgStar, which is a Stargardt natural history study. Can you speak to this audience on the importance of these natural history studies and our ability to sort of address what you've just mentioned, Paul, and that's the significant variety and clinical heterogeneity that we see in these patients, including slow versus fast progressors?
Sure. Yeah, I was part of the ProgStar study, and I think the Stargardt community can be proud that was really the first very, very well done, large scale natural history study sponsored by the Foundation Fighting Blindness of a disease such as Stargardt disease. And what we did is multiple sites, I think it was at least a dozen, if not more of us, enrolled as many Stargardt patients as we could and followed them for 2 years using all of the state-of-the-art imaging and really trying to learn how fast does this disease progress and how does it progress. And we learned a lot with this study. We learned that it progresses slower than, in terms of the changes in the autofluorescence, it progresses slower than age-related macular degeneration. And it gave us targets that the drug companies have absolutely taken to heart and are using to design their clinical trials. Also, since we know the genetics of almost all the people in the ProgStar disease, we can do secondary analyses and look and learn more about all of these mutations. So this ProgStar is really held up as a model. We've published many, many different papers. And I think the pharmaceutical community has really benefited from the investment that the Foundation Fighting Blindness put in on this. And we're now doing this similarly for Usher disease and other things that are coming along. But the database that we have is fantastic, but it still doesn't, people who were didn't quite fit the mold of, having atypical, some maybe milder disease or some of the severe disease didn't get into the study. But we now, for the typical Stargardt disease, we know, for the average Stargardt disease patient, we know a lot.
Right, and you mentioned age-related macular degeneration. Can you have both? Can you have AMD and Stargardt?
Yes, you can. And it can be confusing. We've learned that some of what we called late age-related early onset age-related macular degeneration is actually just later onset Stargardt disease. And then you factor in, we know many other mutations are associated with age-related macular degeneration, but having problems with your lipofuscin and vitamin A processing certainly has we can envision ways that would enhance progression, perhaps, of age-related macular degeneration as well. So everyone's got all these mutations, and going the other way, I think, is an interesting question, which I don't think has been investigated. So if you have Stargardt disease and have the classic mutations in ABCA4, are the mutations associated with, or the variants associated with age-related macular degeneration in complement and in something called HTRA1 ARMS 2? Does that make Stargardt worse? And I don't know about that. Has anyone looked at that, Janet? I've never heard of that study. Have you?
No one's done it. There's been attempts to model that in mice, but there haven't been any human subject studies.
Yeah, I think that would be interesting.
Is that classified as a modifier of disease?
It could be. You're just kind of saying it would be a modifier of Stargardt. I've never seen that looked at systematically. Mm-hmm. But as we get to better in informatics, and I think that's something that might explain. But there's so many other genes out there too that could be involved.
Yeah, and Janet, maybe you can follow up on that. This is the genetics of IRDs and Stargardt is unraveling before us. Maybe you can just tell this audience, which is a pretty educated audience, on what a modifier is.
Well, yeah, so a modifier could be something that actually aggravates the ABCA4 mutation, or aggravates the presentation, or it could be something that tempers, reduces the presentation of the ABCA4 mutation. One of the ways in which people have been interested in modifiers is by looking for genes and other factors that might potentiate the accumulation of the damaging vitamin A derivatives, that could be a pathway by which a modifier could could work so that the modifier could actually increase the amount of these damaging aldehydes that are produced. At the same time, you could have a modifier that decreased the production of these damaging molecules. At this time, however, no one really has come up with sound evidence of modifiers, although they're probably out there.
Thank you. Okay, so let's go back to the pharma side of things. There are a few questions on specific treatments, opinions on RNA therapies, including antisense oligonucleotides for Stargardt.
Actually, I don't think there are any ongoing studies targeting RNA. Am I correct about that, Paul?
I think I'm not aware of one either.
Yeah.
Because we have a dysfunctional gene that we would like to function better. So there are other conditions where we're trying to knock down a toxic gene that has that's caused by a mutation. So I don't think that's one that's being targeted for Stargardt disease.
The only one that we're aware of is ProCure's antisense oligo approach, but it's an very early stage program.
Yeah. I think there's so many different mutations that might be hard to do.
It would be difficult.
Right.
That could be if there was a known modifier. Maybe the RNA targeting the RNA could be an approach that would be used, but I don't know of any currently.
Yeah.
So most common are the hopeful drug therapies that would target the vitamin A cycle, target how much vitamin A is actually allowed to get into these retinal cells, and then what the vitamin A is doing when it's in that cycle. Most of the therapies are looking for approaches that would work on that visual cycle.
Yeah, I think I just want to emphasize how special Stargardt disease is in that we know an enormous amount about the biochemistry of what's going on in this disease, more than most other inherited retina diseases. I think that's why there's so many different small molecule approaches that are being tested out there.
And Paul, you mentioned the prevalence of Stargardt disease, 30,000, and that's in the US. There are almost 100,000 patients worldwide, which is probably the largest IRD prevalence that we have. Janet, I'm sorry I interrupted you.
Oh, that's okay. I was just going to add to what Paul was saying, and that there are many complications that are presented in recessive Stargardt's disease. Another is one that I mentioned at the beginning of the hour, and that is that the gene mutation is sitting in one cell, and the actual damage is being mediated in the adjacent cell. And so this is another it's an interesting predicament for many of us investigating the disease, but it's also something that adds complexity.
Is it true that the more vision a patient has left or remaining preserved, the better chance he or she will have with treatment outcomes?
We think so. I mean, certainly in the extremes that, in the end stages of the disease, if there are no photoreceptors working, putting in a small molecule or other is not going to change much, or even gene therapy is going to be a big problem. That's where restorative approaches such as stem cells become the preferred approach. So yes, the answer is we would love to intervene earlier, especially if we know the natural history. You could go to the extreme where you have, say, a family where one sibling is already known to have Stargardt disease, and they're younger. You could then test the younger siblings to see if they have the 1 in 4 chance that they also have the same mutation, and you may identify a 5-year-old who has a perfectly normal eye examination, who has the mutation and is, we know natural history-wise, is going to run into problems in 5 or 10 years. So this would be an ideal situation, you think, if you had a safe and effective treatment. You'd want to intervene at that point when they, with gene therapy in the very, very early stages when there's more to save. But as I emphasize, it has to be safe and effective. If it's high risk, then maybe you don't want to do it. So that's where we are right now.
Thanks, Paul. This is a follow-up question. And by the way, we're 10 after 12, so we have time for 1 or 2 more questions. You mentioned the typical Stargardt patient, and I think this was in response to the natural history study, amid the typical progress. So what is the typical Stargardt patient?
So the classic kind of teaching is that this is someone, if there's no family history, and there often is no family history in Stargardt disease that's known because the parents are just carriers, and but if a common presentation is someone in their high school years or early adult years where the vision is just not quite right. They're not seeing the board if they're looking up, or they're having difficulty reading small print, etc. They then see, 25 years ago, they would see their eye doctor and they would look in and maybe they'd see something, but often we didn't have very much right now. Now or back then, now we do, when you see your eye doctor, they'll do what's called optical coherence tomography. They'll do autofluorescence imaging. We pick up the disease much, much earlier. So with the average Stargardt disease, as I said, it's young teenagers and young adults. There can then be a lot of variety. Some patients do fine and slowly progress over the next years. There are others that can have a fairly significant downhill course over a period of just 2 or 3 years and drop to 2200 to legal blindness. It then stabilizes in the classic cases and doesn't get much worse. And I have many, that I can think of, many very high functioning Stargardt patients who have gone on to get PhDs, become lawyers, and they have challenges, but they do very well. There unfortunately is a wide spectrum though, and some patients really can become very debilitated with some of these ABCA4 mutations. And so the youngest patients that we typically would ever see are, say, age 5. They often have, if they present at a very young age, at age 5, that can be a sign of a fairly aggressive mutation that's going to be causing problems. There are other people that I have diagnosed that are, for example, that have been, physicians, doing fine, but suddenly start developing problems in their 50s and 60s, and that can cause disability and other problems too. So it's so variable, but an average is 10, probably between age 10 and age 30 would be the most common time that we would start seeing this. And they often are misdiagnosed for a while and handed around to doctors before we figure it out. And now genetic testing can nail this down fairly quickly and definitively.
Dr. Sparrow, any comments to add as we conclude the session?
I hope we've been helpful to some of the participants. We are very grateful for their support in providing us with the funds and invigorating interactions that propel us forward in working harder and harder. And I'm very optimistic about treatments becoming available for recessive Stargardt disease in the coming years.
And the short answer to your hope that this was helpful, Janet, is that I'm receiving statements from many of the attendees that this was extremely informative. So we want to thank you, Dr. Sparrow and Dr. Bernstein, for your contribution to the field and your service to the foundation. You're terrific individuals. So thank you for being a part of our organization. And thank you to the attendees for participating as well. And if your question was not addressed, and there certainly are a few, please email info@fightingblindness.org, and we'll make sure that your questions are addressed. So this concludes our session. I hope you all have a nice weekend, and take care and be safe.
Thank you.
Thank you very much. It's been very, very, very fun to participate.
Thank you. You all take care.